So good afternoon, everybody, and welcome to today's Asia Pacific Stats Cafe. It's my real great pleasure to be with you here this afternoon, and a real honour to introduce Romain Thanton, who's on the just put his video on there now, and Martin Bracci, who's they're the Deputy Director and Regional Deputy Director of Vital Strategies, who are one of our key partners here in Asia and the Pacific, really focused on improving civil registration and vital statistics systems, and working regionally as well as with countries to improve civil registration and vital statistics. Been a long partnership, a very successful one, and it's really great that we're able to be working with you here today. And it's also my great pleasure to welcome everybody to today's cafe. Since COVID, well, we've all been working for a long time to try and improve civil registration, vital statistics, but since COVID-19 hit the region in earlier this year, you know, a real extra focus on making sure that we have very good death registration, very good information around causes of death, and really accurate information, registration systems, as well as statistics coming from those. And this whole area of rapid mortality surveillance systems, I think, offers some really great potential to, you know, put in place some, or as we call it, rapid, put in place some processes where we can, improve death registration, improve death statistics, while we're still working on the longer term aim of really strong civil registration vital statistics system. So it's my great pleasure to introduce today's cafe. But also, I just think it's wonderful that we're going to be hearing from Dr. Adnan and Ms. Anushka from Bangladesh to share with us the experience of one country in our region of how they've used rapid mortality surveillance systems. So without further ado, just very briefly, the rules of engagement. This is MS Teams. We're very open to questions. We've got a couple of presentations, and then we've got lots of time for question and answer. Please use the chat box in MS Teams or put your hand up, and Martin and Romain will manage this cafe today, and have a lot of time for interactive dialogue. So without further ado, Romain, very pleasure to hand over to you. Thank you very much.
Thank you so much, Gemma, for your introduction, and thanks a lot to you and our ESCAP colleagues for having us today at this Stats Café. I will start sharing my presentation, and shortly after that, I will hand it over to my colleague Anushka, who will be giving you a little bit more. I will give an introduction. Anushka will give a little bit more of a country implementation perspective, and our colleague from Bangladesh, Dr. Adnan, will give a perspective from the Bangladesh stakeholder side. I will do a brief introduction, a description of the RMS systems, and explain a little bit about establishing baseline, excess mortality analysis, and data use. So the reason why we are implementing rapid mortality surveillance is because around the world there is a lack of testing of COVID-19 that leads to some uncertainty. And counting COVID-19 cases, it's actually fairly complicated. The testing is usually restricted to clinical settings, and there are many more non-fatal cases that can be confirmed as consequences of the pandemic. So this is challenging, and on top of that, counting COVID-19 deaths can be delayed. There is a need to report to a central level, to implement ICD rules, and for systems that are not fully digitized, this may be even more challenges and really take time to produce data. On top of that, we usually have access to hospital data, which alone is not sufficient to have a full picture. In Developed countries, I would say that this is more of a rule that death occur in facilities, but in many other countries, it's rather the norm that a death will occur in community. And in some places, it can be up to 70%. And under pandemic condition, it can even increase beyond this because of overstretched health care system and change in care-seeking behavior, because people will be concerned about going and seeking care outside of their community. So we need some means to account for this death as well, and this is where the rapid mortality surveillance, or the rapid surveillance of all death and with all causes, it's coming, and that provides us with some awareness of the trajectory and distribution of the health impact. It helped to generate mortality information quickly and rather in a simple way. It will help to account for all deaths by age, sex, and place of occurrence, which will be rather convenient for some further analysis. It will cut any ambiguity and delays in attending to assign a cause of death, which can be inaccurate due to lack of training and lack of testing. It would create ability to use cause of death data where they are, of course, already available to analyze excess mortality. So cause of death can be used, of course, but we just don't want it to delay the process. And of course, we recommend that to leverage existing system and fill performance gaps in CRVS systems. So to kind of use other systems that are available. And on the right side of your screen, you can see a graph here that shows how this excess mortality is being displayed, and you can see that the green part, it's the usual the baseline data from previous year, and the dotted line in blue, it's the current death, and you can see a peak at some point, which is showing this excess mortality. This is for age group 50 years and above in Switzerland, and it was in the beginning of the pandemic in mid 2020. So I will quickly describe what a rapid mortality surveillance systems looks like. And here it's shown in a rather simplistic way. You have, several sources, which are either facility-based reporting, either community-based reporting, and your medical legal death investigation system. And the idea is to gather all the information coming from there and to have a daily, ideally daily, if not possible weekly, transmission of all this information to a central level where the data will be compiled, the quality check will be applied, and it will be analyzed against what you see on the left of your screen, the historical or baseline mortality. And then it will be brought up quickly to policymakers for rapid decision making. Of course, there is additional system consideration, for instance, the selection of sites. If it's not possible to do it countrywide, some sentinel sites will have to be carefully selected and to make sure that it's as representative as possible. And therefore, some additional sites can be focused on vulnerable population to try to have the most accurate picture. Then it's very important to have at least, or to have the 5 data elements for every death, which are date of death, age of death, sex, location of usual residence, and place of death, and particularly to understand whether it's happening outside or inside a health facility. Of course, to be able to compare, you will need to be able to gather some historical source or estimate of baseline mortality. And the question about cause, well, as we mentioned earlier, the investigation of the cause can be something that can delay. So where feasible, yes, but if it slowed down the reporting process of total mortality, then it can be done subsequently. So what are the output of the rapid mortality surveillance system? First of all, you get indicator by number of death by age, sex, and location. And then you also get some death rate by age, sex, and location. And then you also get some % deviation from historic estimated average death by all the different data that you are collecting around sex, age group. You are able to disaggregate by age group, location of usual residence, and place of death, whether it's inside or outside of health facility. So all these create the ability to see changes from historical norm of mortality and understand a little bit the progression of the pandemic, and therefore do some, targeted policies, whether it's geographical by age group, or to try to really understand how the pandemic is progressing. I will briefly explain you how to establish baseline mortality and how to analyze the excess mortality, but Anushka will get into those details a little bit later. And basically, it's rather straightforward to calculate your expected death. You will ideally look at 3 to 5 years of historical mortality data by week, sex, and age category. It's important to have those variables there. And if you do not have historical baseline data, then it's good to compare trends over time as implementation occurs, or estimate mortality rate based upon population projection. Of course, you will have to adjust for admission data in facility, for instance, and population data for communities. And the tools that can be used is excess mortality calculator and various templates. And Anushka will show you in more detail the excess mortality calculator. And then it can be displayed with such graph, which is pretty similar to the graph that was shown earlier, where you can see the deviation from your baseline data, which is here represented in blue, and the dotted line in green is the current mortality, and you can see the difference in between the baseline and the current, which is your estimate of excess mortality. When it comes to data use, it can be used to monitor direct and indirect mortality-related impact on the population and healthcare system. It will monitor impact of public health measure and mortality, identify specific high-risk group and disparity in disease burden, and expose gaps in disease surveillance. And this is very important that those data do not rest on a shelf or on a computer somewhere, but is shared with decision maker to inform action on an ongoing basis. So the rapid mortality surveillance it's helped to produce real-time mortality data, and it's critical for routinely monitoring public health in emergencies. Of course, it's good to try as much as possible to leverage CRVS system. So not to kind of create parallel system, but try to leverage on the existing system that are already in place in the countries, and try to see how they can perform faster instead of, again, creating new sources of data. It's good to try to use existing and use that opportunity to strengthen the CRVS system. Where real-time mortality surveillance is not available, then short-term rapid mortality surveillance approach can be used to establish real-time mortality data. RMS should leverage existing system, as I mentioned, and the real-time mortality surveillance can generate estimate of excess mortality, and therefore helps to understand disease transmission and identify and mitigate health threat. So before I hand it over to Anushka, I would like to point out that you can see more information around the rapid mortality surveillance, and particularly how to implement and what are the recommendations through this technical package that was developed in partnership with other CRVS partners, including our colleague from ECA and ESCAP. And there is also a link to the excess mortality calculator tool that Anushka will introduce later. Those links will be shared after the RMS Café. Thank you very much. And Anushka, I will exit the presentation so that you can continue.
Thanks, Romain. Can everyone see my screen? Okay, it looks like it's visible. Good afternoon, everyone. My name is Anushka. I'm a technical advisor with Vital Strategies. Um, I, I help look after the CRVS improvement program in Bangladesh and Cambodia. And my presentation this afternoon will be on the technical implementation of rapid mortality surveillance in Bangladesh.
Anushka, I'm really sorry to cut you off. Is there any way you could make the presentation slide a little bit bigger and make it full screen?
Yes, sure. I think that, yes. Duplicate slideshow. Is this better, Daniel?
We're actually seeing the presenter screen where you can see the little next slide on the right-hand side.
Right.
Okay, let me exit and share my screen again.
If you can't, it's okay. We don't want to spend too much time on it.
I think I should be able to do it. Just give me 1 second. I think it works now, right?
That's great.
Okay.
Thank you very much.
Thanks for bearing with that. So yes, as I mentioned, I'm going to present the technical implementation of rapid mortality surveillance in Bangladesh. As my colleague Romain already explained earlier, the objective of rapid mortality surveillance is to see how we can count all deaths and compare this with historical mortality data. And this is exactly what we wanted to do in the context of Bangladesh as well. The intent was to basically capture both the direct burden of the COVID-19 epidemic, but also the indirect burden of mortality that's caused by disruptions to accessing health services, the use of healthcare services, as well as the provision of these services during a pandemic like the one we're in right now. And of course, the intent with doing this exercise and this analysis was to relay the information and the analysis that we were able to produce to the emergency response unit of the country for better decision making during the circumstance. So before we went in to technically implement the rapid mortality surveillance work in the country, there was a lot of groundwork that needed to be done. And the key one was to basically sit together with our country stakeholders and to define country objectives. Getting buy-in from relevant ministries, development partners, local stakeholders was essential. And it was also really important to identify the scope of this mortality surveillance because, as you know, deaths can happen in facilities, but in the community as well. You can also have them take place in urban areas, in rural areas. And so it was really important to narrow down the geographic locations or the specific sites in which we would conduct this excess mortality surveillance and analysis, and on the key populations that we would focus on. And then, of course, based on the specific country objectives, it was important to identify specific indicators that we could measure to see the outcome of this exercise. And also, I think it's important to to differentiate between the short-term and the long-term goals of the rapid mortality surveillance work. In the short term, it was really to try and capture as many deaths as we could in real time, which meant trying to get reports from various parts of the country where we were doing this surveillance on a weekly basis, if possible. But of course, this feeds into the long-term objectives of a strong CRVS system. It feeds into the objectives of building a robust CRVS system that covers mortality surveillance and death surveillance in general. But before we went out to set up a rapid mortality surveillance system, it was also important to make sure that we didn't reinvent the wheel. And basically trying to identify existing trying to map out and identify existing sources of mortality data, and the existing mortality information landscape was also imperative. This was important to assess the coverage of data, the completeness of it, as well as the quality of data. And not only to look at data in the present day, but also to look at whether these sources had baseline data available from previous years, so that whatever analysis or trends in mortality we were able to look at could be compared to um, a comparable time period in a previous year. In addition, we also didn't want to set up a new system when systems already existed. So were there ways in which we could modify or adapt existing systems so that we just tweak them a little bit in order to obtain death information on a more rapid basis, or were there electronic systems that could be leveraged? And specifically, an example in the case of Bangladesh was we were really able to leverage a network of health assistants that's already very plugged into the community, and whose role it is to kind of capture death notifications in their respective jurisdictions, but to do so on a more frequent basis than they were currently doing. And of course, once we looked at that entire landscape, looking at the resources and the implementation requirements was also essential. So what sort of human, financial, technical resources were required, and how could we put in place additional protective measures to keep the surveillance workers safe? So these questions, of course, require a lot of time and discussion and numerous meetings. And based on that, we were able to actually narrow down on 4 sources of mortality data from Bangladesh, some of them pre-existing and some of them which required a little bit more effort to gather. But overall, these sources were like the sources of mortality data from these 4 different different data sources was to paint a picture of mortality throughout the country. And these include data on community deaths, which is already being routinely collected in the form of death registration data. But just during the pandemic, when we wanted some more frequent reporting, there was a temporary real-time data collection system that was set up through the health assistants to report more frequently. They do this anyway, but the reporting frequency during the months of May to October was rather rapid. It was weekly. In addition, we also looked at facility deaths, and DHIS2 actually provides a wealth of information when it comes to facility deaths, because hospitals are constantly reporting the number of deaths that occur on a weekly or a monthly basis, as well as the number of admissions and discharges. So having access to that information was really important in being able to plot mortality trends and to look at it in comparison to historical data, which also comes from the same source. So it's a good comparison to look at. And 2 other sources of data we looked at was from burial sites, which is a rather labor-intensive effort, and it's not as rapid, not quite as rapid as getting data from the existing community and facility sources that we have. But it is something that we thought was worth looking at, just to see if there have been increases in burials in specific regions within the country. And finally, with one of our partners, ICDDRD, we are also looking at mortality data in 2020 and in previous years, because they have access to this data at HDSS sites. So the last 2 are kind of sources that we've only started looking at a little bit more recently. And my colleague, Dr. Adnan, who's from the government of Bangladesh, should be presenting a little bit more on the community and facility death data and what it shows. But before I wrap up my presentation, I would really like to share the tool that we use in order to analyze excess mortality, and that's the excess mortality calculator. So my colleague Romain alluded to the technical package that was developed by a number of different stakeholders. And the excess mortality calculator is really the main tool that's used in order to be able to plot mortality trends and to look at it in comparison to historical data. So I'm just going to switch my screen to another spreadsheet. Let me reshare this. This is just the tool that I would like to share. Right.
So Anushka, I don't know if you meant to, but you actually stopped sharing your screen.
Oh, oops, sorry. I did, but can you see the Excel spreadsheet now?
Yeah, it's coming through now.
Right. Okay. So this is the tool which I refer to as the excess mortality calculator. It's basically an Excel-based calculator that helps countries to input their historical and current year data broken down by week, so their mortality counts or their death counts by week. And basically, the calculator does everything for you when it comes to calculating things like the confidence interval and all the other statistical analysis. So there is an example that's provided in the calculator, which is from England and Wales. And if you look at columns B through F, there's historical data from 2015 to 19 that's been recorded. These are the total mortality counts by calendar week of the year. And then the 2020 data, which gets updated on a weekly basis. So, so once these numbers are input into the calculator, all of these other statistics are automatically calculated, and it also produces these really interesting graphs that show mortality trends in the present year in comparison to the historical baseline. So if you look at this particular graph, the red line actually shows the mortality trend for 2020 by week. And the gray section of the graph is actually the confidence interval from the past of deaths from the past 5 years for that same week of the year. So I think using this tool in different contexts can produce interesting representations or interesting analyses of how the mortality trend in countries have changed, especially this year given the pandemic. And actually, this tool is available on the Prevent Epidemics website, which I can share the link. There we go. I can share the link in the chat, but it's just a very easily downloadable Excel, and you could use that for your own analysis. Yeah, so that actually brings me to the end of my presentation. And I'll let Dr. Adnan continue with his sharing of the Bangladesh experience of rapid mortality surveillance.
Thank you very much, Anushka. Hello, Dr. Adnan. Can you hear me?
Yeah, I can hear you. Hello?
Yeah.
Yeah, I can hear. Okay.
Okay.
I'm going.
Yeah, you're trying to share your screen now?
Okay, I'm going to present my presentation now.
Yes, please go ahead.
Okay, my presentation is rapid mortality surveillance from Bangladesh perspective. Can you see my presentation?
Yes, we can see and hear you fine.
Okay. First, I'd like to say the introduction. Reliable cause-specific mortality data constitute a crucial resource for health monitoring, service planning, and prioritization. However, in the majority of the world's poorest settings, systemic health and vital event surveillance system are weak or non-existent. As such, deaths are not counted and causes of death remain undersigned, unregistered for more than two-thirds of the world's population. At the end of 2003, data on death registration were available from 115 countries, although they were essentially complete for only 64 countries. I like to say the background of Bangladesh. Number of sub-district is 493. There is 8 division and district is 64. Total population approximately 160.5 million, and population coverage under community RMS 4 million. Crude breath rate is 5.1. This is national, and estimated facility rate is 15% estimated, and community rate is 85%. First COVID-19 cases were identified in Bangladesh on March 8, 2020. Total number of confirmed COVID-19 cases 0.489 million. Total number of deaths till day before yesterday was 7,020 due to COVID-19. 7,020. And you see, this is the map of Bangladesh, and the sub-district we are locating. Of them, the of the 13 sub-districts are in here where RMS is going on. Community rapid mortality surveillance is started in 13 sub-districts where Caligan's model are implemented. Health officials of 13 sub-districts and 8 districts were trained. Around 650 as health assistants and 130 supervisors were trained. RMS has been started from 10th May 2020 in Bangladesh. A monitoring team was formed in Management Information System of Directorate General of Health Services, that is central level, and RMS data are monitored and feedback to sub-districts on weekly basis, and surveillance week starts Sunday and ends on Saturday. Community RMS source is historical death registration data of 13 upazila from BDRS and current death notification data of 13 upazila by health assistants using RMS data collection template. And facility RMS still there is 2 points actually. Number one is DHS2 is not integrated with RMS till now, but the death occurred in the hospitals are captured by the MCCD module on that areas. This is the data collection format for community rapid mortality surveillance. This is the form, collection form. And the benefit of RMS in Bangladesh is establishment of registration systems for entire population is unlikely to occur in the short to medium term in Bangladesh. In the meantime, sample-based and sentinel population and mortality surveillance can yield sufficiently reliable and relevant information for Bangladesh. The data and evidence should be used while efforts continue should be made to improve the evidence base. RMS data is used to calculate excess mortality for a population of Bangladesh that has high level death registration or facility death. Here you can see a graph which shows Bangladesh 2020 death in people of 0 to 59 years and 60 plus years by week compared to the upper and lower limit with 95% confidence interval of historical average. Here you see up to 49 week data has been included here from week 1. Okay. And the response COVID-19 since the initial outbreak of COVID-19 in Bangladesh earlier this March, Bangladesh is at an economic and social standstill due to the government-imposed nationwide lockdown. Although every sector of the country is facing the problem, the health sector is currently among the most affected sector of the whole. And RMS activity affected by COVID-19 and it is not integrated with as it is not still with DHS2. So only based of RMS, the policymaker is not taking decision yet as because of this reason. And the challenges of implementation of RMS still we face. With the country was fully locked down from late March 2020 to May 2020. Domiciliary visit by health assistant was hampered. Training done on virtual basis. Shortage of PPE for field level workers. Data quality initially was not up to the mark. Extra burden for field workers. Central monitoring team was involved with COVID-19 surveillance. Lack of skilled human resource. Internet connectivity problem. Insufficient dedicated human resource. Absence of interoperability. These are all from my side, and thank you to all. Yeah, that's from my end. Thank you.
Okay, thank you very much, Dr. Adnan. I think we can turn it over to Martin Bracci to make any conclusion comments if you want, and then we can start with the Q&A.
Sure. Thank you very much, Daniel, and thank you to all the speakers for the presentations and also for presenting the case study of Bangladesh. I don't think I will aim to make much more of a conclusion or summary remarks, but rather look forward to interactive discussions about this very important and timely topic. So we have a few questions already in the chat. We will get to in a second. We also have the option of course, adding new questions to the chat. Please do use that function, or you can also raise your hand in MS Teams, and then we will help you to get unmuted, and you can ask your question, and we can have a direct discussion like that. So maybe just to address some of the submitted questions that were submitted with the with the registration. And one of the questions there was how to establish and maintain basically a rapid mortality surveillance system in a case where the Ministry of Health is not responsible for civil registration. And this is the case in quite a few countries, that the Ministry of Health is not responsible for civil registration. However, we think that it's really very important that in general, the Ministry of Health plays an important role in civil registration, even if they are not the authority doing the registering of the birth and death. The health sector is very close to the population, as we all know, often present at birth or death, or within days or hours of the occurrence of those events, and therefore very strategically placed to play an important role in civil registration. And it then requires the solid foundation of coordination mechanisms between the sectors to allow for organizational interoperability. That is to say, to allow for coordination of activities, coordination of data collection tools, and ultimately exchange of information and connection of even IT systems, if that is possible. We do see that particularly during the COVID-19 pandemic, this interaction between the health sector and the availability of data in the health sector for the production of vital statistics is particularly important also then. And we've seen that several countries do that in the region to speed up the production of vital statistics because of the urgent need for this information. And of course, this rapid mortality surveillance is basically one of those methodologies to speed up the production of vital statistics, maybe from sample sites, maybe only from health facilities, but really to get very timely, basically weekly insights into what's happening to the mortality data. And it's true that under the circumstances of the pandemic, it may be necessary to consider some data transmission channels that really allow for that timely transmission. Still be linked to civil registration, but possibly get information about notifications of death as opposed to wading through the full process of registration and archiving and then only being able to produce vital statistics from that. So I think that the fact that the Ministry of Health is not responsible for civil registration is not necessarily a limitation. However, it does need to be addressed with aspects of coordination and so on. We then, sorry, I also wanted to, Daniel, maybe if you could keep track of time and just let us know if we are like 5 minutes before the end or something.
Sure. Yeah, I'll chime in and let you know where we're at. Okay,
great. Thanks a lot. We then also had a question about the evaluation of completeness, which of course is an important question, always to understand, well, what is the expected number of deaths, and is the system reaching that expected number? And as you all know, there are various methodologies to assess completeness. There is kind of a gradient of complexity, let's say, to those methodologies. Some that are using international estimates to see what the expected number of deaths should be. There can also be local estimates based on information from the census or, for example, an HDSS sites. And then there are much more complicated methodologies which actually involve household surveys and so on, which of course at the current times wouldn't be really very practical. So as Romain also pointed out, I think for the purpose of rapid mortality surveillance, use of historic data is very important, just to see, are the systems performing at the historic level? Are current systems collecting the same number of deaths as was in the historic baseline? And then other maybe some of the other more complicated methodologies to assess completeness can be evaluated. There's also some more recent methodologies that have been developed. So different options available there. Then we also had a question around the evaluation of the accuracy of cause of death data, and maybe Romain, if I could ask you to respond to that, please. Thank you.
Sure. Well, actually, there are some tools that exist to check the accuracy of cause of death, such as ANACODE, which is a tool developed by the WHO, or Anaconda, another tool that was developed by University of Melbourne under the Data for Health initiative. And of course, this will give you a broad picture. So if you want to do something a little bit more precise, you will have to go and check in the accuracy of your ICD coding, just to make sure that the final underlying cause of death has been properly identified. You can go also on the medical certification of cause of death, just to look at the information there and select a sample and look at the quality and accuracy of all that. And you can also go all the way back to the medical records to try to see if anything has been missed in terms of comorbidities, for instance, or in terms of testing. And I will also recommend to look closely at the latest WHO recommendation in terms of medical certification of cause of death, with some guidance around COVID-19 on whether the case was confirmed or is a suspected case, and also in terms of applying ICD mortality rules.
Great, thank you very much. Yeah, so definitely tools are available to assess the accuracy of causal death data at the aggregated level. And then there's also tools available to assess individual medical certificates. And both of those aggregate level assessments, as well as the assessment of individual medical certificates, is critically important to understand the quality and then to be able to address the quality as well. Thank you very much for that. We then had a question around the training program for rapid mortality surveillance, also asking if there was work together with medical schools to implement this training. Maybe Dr. Adnan, can I ask you to answer a little bit regarding the training approach that you've used, or that was used in Bangladesh, to train the staff for rapid mortality surveillance? Thank you. Dr. Anand, please go ahead.
Yeah. I'm hearing. Yes.
Okay. Yeah, go ahead.
Yes, the training. Yes, the training has given to the field level by online. Online training has been conducted because due to COVID-19, we didn't arrange the physical training
Right.
from center level, and still now. But from last week, we have started the physical training by going to the field level.
Okay.
And yes.
Okay, great. Thank you very much. Yeah, I do think that during these times, it's really necessary to establish a quick method of training. So that I believe in Bangladesh there was no interaction with the medical schools for this. Of course, for other aspects of the civil registration system strengthening, it's very important to work with medical schools to make sure that there's pre-service training of the staff that will be involved. I think another important aspect around training is also that, again, as was mentioned in the presentations, that to really try to build on established systems where staff would already have some training in managing information flows and collecting information about vital events. Yeah, I see there was a question about the exact tools that Romain mentioned, and that was answered with the those two tools. We're happy to also provide links to them. Both of them are available online. I don't know if are there any. Go ahead.
Yes, a very vigorous training will maybe from first week of May go to the field level, because our other training has been started already, physical training, and from virtual training there is some problem and limitation. But when we conducting the physical training, it is better than the physical. So we want to change as well, so that the outcome will be more good, I think.
Great, thank you. Thank you. Maybe Anushka, could I ask you to just say a few words about the training on the excess mortality calculator? Thank you.
Sure. So for the excess mortality calculator, I think the first thing is like referring to the technical package that is published on the WHO website. I think that provides a really good foundation for rapid mortality surveillance in general. But then specifically, in order to use the tool that I presented, which is the excess mortality calculator, that spreadsheet, what we were able to do in Bangladesh is we conducted several trainings virtually on how to use that tool, both with example data from other countries, like I presented from England and Wales, but also using the different sources of data that we were collecting in Bangladesh. So a very hands-on training to see how we could use country level or country specific data to actually look at the mortality trends. And I believe we trained. It started off by just training one focal point at the Ministry of Health, but we've presented the analysis various times to different groups within government. And I think at this point, there is a certain level of comfort with using the excess mortality calculator. The instructions in the very first tab of the spreadsheet are very clearly explain what has to be filled out and what's automatically calculated. So it's a fairly intuitive tool, although it looks a little bit intimidating when you first open it up. Yeah.
Great, thank you very much. Yes, and on the website provided, there is also a little bit of an explanation, and we are hoping to add a video to that explanation very soon to make the use of the calculator as simple as possible.
Yeah, and Martin, I don't know if we have any other outstanding questions, but we only have a few minutes left.
Okay, great. Thank you very much. Yeah, so maybe are there any other questions from the participants, colleagues?
Me AKM Ashraful Haq.
Hello, yes, please go ahead.
Me AKM Ashraful Haq, Project Director, monitoring the situation of vital statistics of Bangladesh project. That is Bangladesh Bureau of Statistics.
Yes, good afternoon. Please go ahead.
We collect regarding information on mortality, that is death and birth, regularly. That is whole year we collect information regarding death. And we in BBS we have a master sample, that is integrated multipurpose sample design. It is based on last population census 2011. We have 2012 primary sampling unit all over the country, and we have also 2012 local data collector, that is all data collector are female, and they collect information whole year, that is 1st January to 31st December. And every year we produce report on Bangladesh sample vital statistics. And we produce varieties type of mortality indicator, that is neonatal mortality rate, postnatal, infant, child mortality, under 5 mortality, like this, and also life expectancy at birth. And we collect, we cover about 300,000 household, and I think 13,000 population. 13,000, not 13,000, 13, that is, I think 1.3 million population we covered every year. And we also produce is an estimated number of death also, and crude death rate, like this.
Great. Thank you very much for that contribution. And I do think that sounds like a system where you may also be able to evaluate any shocks to the system, such as COVID-19, any increase in mortality that is happening in 2020. And I think it would be very interesting to evaluate that and to see whether or not there are any changes in mortality during the year 2020, also as you have a good baseline and would know the expected number of deaths in your sample population. Very interesting. Thank you.
Oh, okay.
I am not hearing. Is it just on my side?
No, I think he's muted.
Yes. Sorry, you're on mute, please.
AK, I don't mean to cut you off, but you're going to have to unmute because we can't hear you.
Yes, please go ahead.
Me?
Yes.
Okay. Already after 2020, that is mid-May or June, we will produce annual report on Bangladesh sample vital statistics, and including COVID, including death due to COVID. And already we are going to process causes of death and by month. That is up to October we have completed, and next November and December we are going to very soon. And I think after 2020 we can produce by causes of death and by month within mid half of the 2021.
Great, thank you very much. Yes, and that a timely production of the vital statistics will be very important to understand the situation in Bangladesh and to understand the situation in any country. Unfortunately, we are coming kind of to the end of the hour. Are there any other questions or comments?
Sorry?
No, I was just saying that we have only, I think, 1 minute left in this Stats Café webinar. So I was just asking if there are any other questions or comments. If not, I thank you all for your questions and the discussion, and of course, again, thank all the speakers for their presentations. I don't know, Daniel, any other points from your side?
Nothing from our side, Martin. I think I don't see anyone's hands up or any other questions in the chat box, so I think we can just go ahead and end there.
Okay. Great. Thank you all very much.
Thank you for joining.
Thanks, everyone.
Thank you. Have a nice